Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And this is of a really interesting case of a patient who attended with a grade 2 Keratosis obturans in this their right ear and a grade 1 Keratosis obturans in their left ear. Before I start discussing the case, I just want to thank you all for being patient with me. Some of you I know have also contacted myself, sent me emails or even rang the clinic to see how I am, because I've not been posting for a while. Everything's okay. I've just been really busy, and also a family member recently was in hospital, so I've just been busy taking care of them. The likelihood is I'm probably not going to be posting as much still over the next few weeks. It's just so busy at work. I've got loads of things happening, which I will update you on in due course, maybe in my next video. But no, thanks for all the concern. Everything's okay. It's just been really it's been really a hectic schedule, and so I apologize because I know some of you were obviously really concerned, but everything's okay, and I thank you for your worries, although everything's all good. So this patient last attended, I think, 2 or 3 years ago, and I did tell them at the time to come every year because of their Keratosis obturans, but it's been a few years, and it's understandable. I think if you don't have any symptoms, you kind of forget that you have got this condition, and it only becomes apparent that you need treatment once you develop symptoms again. So what's Keratosis obturans? A Keratosis obturans is a benign accumulation of keratin. So keratin is a protein found in the outermost layer of the skin that lines the ear canal, the epidermis layer, and more specifically in the stratum corneum, which is the very most outer layer of skin. So the skin, there's multiple layers. I will possibly discuss that in another video that I upload possibly tomorrow or over the weekend. It's of a grade 3 Keratosis obturans. So I've had so both of these cases that I'm discussing, so this one and the one I'm going to upload with the Keratosis obturans grade 3, they're both attended today actually. So I've had a day full of Keratosis obturans. So that video is a lot longer, so I will kind of explain the physiology of the ear canal and the skin layers in more depth in that video. And essentially all this dead skin, all this dead keratin, it should naturally migrate out of the ear. I compare it to a snake shedding its skin. The only difference being is when a snake sheds its skin, the snake exits the skin. In the case of the ear, the dead skin should exit the ear. So the skin that lines the ear canals, it's like a conveyor belt. As it dies and sheds, it moves sideways gradually towards the entrance of the ear, where eventually it falls out in flakes. But with Keratosis obturans, the skin fails to migrate in the normal way. So they're going sideways. The skin either stops migrating completely or it migrates to the center of the ear canal, so inwards. And then you get this plug of epidermis skin. It's almost like an onion layer, and the outermost layer is typically white or silvery, so we call that the silvery matrix, which you can see. And a Keratosis obturans typically develops in the bony part of the ear canal, the inner 2/3. It's most common in patients between the age of 20 and 40, so it's not geriatric pathology. Here's me just using the forceps to pull that plug away. And the main symptom of Keratosis obturans is ear pain, and it's a very acute pain. It's not a dull pain. So whenever a patient contacts our clinic, my clinic manager and my assistant clinic manager, when she's covering the phones, they are triaged to ask some basic questions. So it provides me with some pre-knowledge. So, and one of the questions is whether they've got any ear pain. So when reading the clinical notes prior to the patient entering whilst in the reception area and before they enter the clinic room, when I review then their initial triage notes, if they've got pain. So I'm always suspecting keratosis obturans. And of course it creates a hearing loss, sound can't conduct through. And there's 4 grades of keratosis obturans. So I'll explain that in a moment. So what I'm doing here, I'm just trying to see if I can peel this layer of dead skin that's going to eventually form another plug of keratosis obturans. But the skin just wasn't ready to be peeled. So we're kind of literally on the bony part of the ear canal, making contact with the bone actually, because we're trying to lift this away, and it just wasn't coming away. So you don't want to obviously continue in that case, because it can be uncomfortable for the patient, because we're making direct contact with the bone. There's no kind of ulceration here, there's no discharge, so I'm not concerned by other pathologies such as canal cholesteatoma being one, and this patient's got, as I said, a history of keratosis obturans, so we kind of know that's what they've got. So in this midsection of the ear canal, they have got a widening, and that's as a result of the keratosis obturans. It's a process called bony remodeling, and I will explain that in a moment. So the 4 grading systems of keratosis obturans. Grade 1 is your kind of milder case, where a patient can attend with mild pain. There may not be any notable widening of the ear canal with a grade 1, but with a grade 2, their pain could be mild to moderate, and there is a mild expansion of the ear canal where this patient has got a mild expansion of the ear canal. And with keratosis obturans, it's typically it's more global, it's over a larger surface area. With a canal cholesteatoma, for example, it's very localized. With benign osteonecrosis, it's typically on the floor of the ear canal, the base of the ear canal. Here it's kind of inferiorly and anteriorly, also some posteriorly, so it's more global with the keratosis obturans. With a grade 3, the patient has moderate to severe pain, and they've got more substantial widening of the ear canal. But importantly, the main difference between a grade 2 and a grade 3 is granulation tissue, which is inflammatory tissue, and it's typically present at the osseo-cartilaginous junction, so where the bony part of the ear canal meets the cartilage part, so it's about 1 centimetre of the way in. And in the grade 3 case that I will upload either tomorrow or the weekend, they had a substantial amount of granulation tissue. And with granulation tissue, it has its own blood supply, so it undergoes a process of neovascularization where new blood capillaries are formed within the inflammatory tissue, and so you quite often get bleeding with a grade 3, not because we've lacerated the ear canal, it's just because as you're removing the granulation tissue, which is in contact with the keratosis obturans, these new blood capillaries burst and you get bleeding, there was quite a lot of bleeding actually in the grade 3 case. And your grade 4 is severe pain and severe expansion of the ear canal. So the ear canal can be remodeled in such a way that it enters the mastoid bone, which is the bone behind the ear canal, or it can also go anteriorly as well, towards the temporomandibular jaw joint. So, and sometimes with a grade 4, you may get some facial nerve involvement. So the facial nerve runs in the posterior superior quadrant of the ear canal. So in the case of this patient, this is their left ear, so the top between north and east, in that region, the facial nerve runs in that area. So if the keratosis obturans expands the ear canal so much that it comes in contact with the facial nerve, they can get facial palsy, so a droopiness on one side. So what's bony remodeling? So with the keratosis obturans, this skin plug, and the best analogy to give it, it's like a rubber ball, and it just gets bigger and bigger and bigger, and it starts to compress against the bony part of the ear canal. Now the sheer force of that rubber ball, that rubber plug of skin itself, isn't sometimes enough to cause the bone to kind of be pushed outwards, and that's some doing, because the bone that encapsulates the ear canal is a temporal bone, and it's considered to be the second strongest bone in the body behind the femur. Now, the main reason why the ear canal widens in the bony portion is that when the plug of keratin makes contact, when it's compressed against the canal walls, it activates osteoclasts. Now, osteoclasts are specialist cells that sit on the surface of the bone, and the job of osteoclasts is a process called bony resorption. So what the osteoclasts do, they break down the surface of the bone into its core minerals, and they redistribute these minerals that it's broken down to other parts of the body where new bone can be formed. So it does that via the blood supply. So it breaks down the bone into its minerals and redistributes it to other parts of the body via our bloodstream. And the bone in our body is continuously doing that. So the outer layer of most of the bone in our body is continuously recycling itself, and it does that as a preventative measure of developing any sort of infection. So there could always be bacteria and fungus, viruses sitting on the surface of the bone. So by the bone itself replacing the outer layer on the surface via these osteoclast cells, via the process called bony resorption, it then develops new bone to replace it. So it's kind of recycling old bone continuously to make sure the bone's always healthy. But with the Keratosis obturans, the osteoclasts are active, but the osteoblasts, which are the opposite type of bone cell which forms new bone, isn't. And that's because it's a continuous pressure applied, and this continuous pressure applied by the Keratosis obturans overstimulates the osteoclasts, so it kind of outpaces the osteoblasts. So you get this bony remodeling, so the ear canal can widen. And once a patient's got a widening of the ear canal, they're going to need regular cleaning, because when you've got an abnormal shaped ear canal, the skin fails to naturally migrate. Now, you can get many reasons why people get Keratosis obturans. Now, you can have kind of skin conditions in the ear like eczema or dermatitis, psoriasis. So keratin formation, so dead skin formation in the ear, is triggered by increased blood flow. So anything that causes inflammation in the ear, so it could be even poking inside your ear, you're going to create inflammation and therefore increase blood flow. The more blood flow you have to the ear, the more skin cells that are formed, and the more skin cells that are formed in the ear canal, the more dead skin that you're eventually going to have, because that skin's eventually going to shed and it can form into a plug. And so treatments really are just cleaning. Sometimes you can have anti-inflammatory drugs to reduce this inflammation, reduce the blood flow. And sometimes they can, an ENT surgeon can either patch up the widenings using split skin grafts, or they can perform a canaloplasty where they widen the other parts of the ear canal to match the widening created by the Keratosis obturans. If you've got more symmetry in terms of the diameter of the ear canal, so if it's more similar from the entrance to the eardrum, you're less likely going to get debris collection and keratin collection within the Keratosis obturans. So this is the patient's left ear. Now this is grade 1 because it wasn't a significant widening of the ear canal, but it was a Keratosis obturans. I have got a still image. Well, I'm going to put it as the thumbnail, so you will see that. I'm trying to just keep the video below 15 minutes because I like to upload these onto LinkedIn for my fellow colleagues as well, but there's a limit of 15 minutes. So so if you're watching on YouTube, you'll see it as the thumbnail, and also on Facebook. So I'm just trying to see if I can peel some more skin. Now this patient previously suffered from a perforation, and you can see that in the posterior inferior quadrant there's a heel perforation. We call it a monomeric eardrum. So it's paradoxically named actually. So monomeric typically would mean a single layer, but in case of the eardrum has 3 layers, and when you have a perforation and the eardrum heals, only 2 of the membrane's layers reheal. So there's one layer missing, and sometimes calling it monomeric, I find it a bit confusing, but you call the healed eardrum, although it has 2 layers, monomeric. and it's essentially because one layer has failed to reheal. So we're just going to be careful there. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.